Hi, can you hear me all right?
Yeah, I can hear you. Can you hear me?
Yes.
Okay, great.
Wonderful.
So
Okay.
many tech difficulties.
Hi, Dr. Santo Domingo. Nice to meet you.
Hi.
Thank you so much
Likewise.
for doing this presentation for us. We're really excited.
Absolutely. It's yeah, Dr. Chiaffini, Eric and I are very working very hard at trying to disseminate the evidence of, what, primary care providers can, you know, do to
Absolutely.
to give them the tools to kind of
Yeah.
help um at least start the treatment and,
Yes,
so
absolutely. I think it's a very relevant topic for a lot of our audience, so we're really excited.
yay. I know. And this is my first time. Eric and I were talking. I was like, back in the, prior to COVID or whatever, there was Dr. Lindsay Borden was our behavioral psychologist that I worked with in the same role that I work with Erica now. And
Okay.
oh my gosh, we were doing all like pediatric trends and primary, like for the practitioner, pediatrics for practitioner, everything. And
Yeah.
so, yeah, I was like, oh my gosh, Erica, this is our first time presenting together. So
Great.
I know
Wonderful.
it's
Um,
not the sexiest of topics, but yeah.
that's okay. That's okay. Um, Really quickly, I don't know if you were planning to or if Erica was planning to share your slides just to make sure that function is
Yeah,
able to
let
do
me
so.
actually, should I go ahead and bring it up? Let me, hmm, yeah, let me do that now.
We have a little housekeeping slide that I'll put up for a little bit before we get started, just for some information for our attendees, but I just want to make sure you're able to
Hmm.
share your screen and that is good to go.
Absolutely, but why isn't it on there? All right. I know it's on my, that is, let me get off of this. Boop. And let me bring that up and let me see how that works. There we are. And then we will go into full. I know I'm screen sharing. All right, so let's go into that. There we go.
Perfect. Okay, great. Wonderful.
There she is.
Hello.
Just taking my time over here.
No worries. We still have some time before we're going to get started.
We didn't talk through who is, are you going to be the slide changer and then I'll just tell you when to move things? Okay, perfect.
Yeah, I have it on there. I wonder, can we? Oh, yeah, that would be better than just to than to
Then to
break
like
and be like, oh,
switch in
you're
the
up.
middle. Yeah. I
I'll
like
try
have
my
this thought of,
best.
yeah. Okay, I'll tell you. I'll just be like, next one.
And are questions going to be like, does someone need to moderate the chat?
Yes, so
Okay.
me and Grace will keep an eye on the chat, and then
Oh, thank
after you
you.
guys are finished presenting, we'll go through and ask if attendees have any questions, and if there's been any place in the chat throughout, we will bring those up for you guys. No worries, we'll keep track of those for you.
I always
Um,
find that's always the hardest is
yes,
to monitor the chat while you're
Yeah.
actually where you're also presenting. So yay.
yes, we will monitor that for you. And they can also there's a Q&A function as well, so we'll keep our eye on that in case anybody puts any questions in there. But we will give it another couple minutes. Welcome to those of you that are joining us. Please feel free to introduce yourself in the chat. Just make sure that you select everyone in the chat function, and we'll get started in a couple minutes. Okay, it is 12 o'clock, so we are going to get started. Welcome, everyone, and thank you so much for joining us. My name is Lily Stavisky, and I'm the Outreach and Training Coordinator for BHIPP. I'll be introducing our presenters for today and facilitating the Q&A at the end of the session. Just a couple of things to remember before we get started. Your cameras and microphones are disabled, so please use the chat function for any questions, comments, or support. You can also use the Q&A function for any questions. Just make sure when you're using the chat to select everyone from the drop-down menu. And we will have 10 to 15 minutes for Q&A at the end of the presentation. If you are participating today to receive CME or CU credit, you'll need to attend for 45 minutes or more to receive your certificate. And all participants who would like to receive credit will need to complete the evaluation survey after the session, which we will place in the chat for you, and we will also send out to you via email afterwards. And the CME and CU certificates will be sent out via email by March 20th, along with the link to today's session, the slides, and a list of related resources. And all of those materials will also be uploaded on our website in the BHIPP training library early next week. And for those of you that are unfamiliar with BHIPP, I'd like to provide some information about our program. So Maryland Behavioral Health Integration in Pediatric Primary Care, or BHIPP, is a child psychiatry access program that supports the ability of pediatric primary care providers and emergency medicine professionals in addressing and managing the mental health concerns of their patients. BHIPP is a free statewide program that offers telephone consultation, resource and referral networking, telemental health services, and training and educational opportunities. And the BHIPP warm line is staffed by a team of child mental health specialists, and it's available Monday through Friday from 9 a.m. to 5 p.m. And we will put our phone number and website in the chat for you. It is my pleasure to introduce today's BHIPP webinar, Medical and Behavioral Management of Functional Constipation in Pediatric Primary Care, presented by Dr. Lisa Santo Domingo and Dr. Erica Chiappini. Dr. Santo Domingo is a seasoned primary care pediatric nurse practitioner with over 16 years of experience at Johns Hopkins Hospital in Baltimore, Maryland. She serves as the medical director of the Pediatric Multidisciplinary Chronic Constipation Clinic within the Division of Pediatric Gastroenterology, Hepatology, and Nutrition. And in addition to her clinical practice, she's dedicated to educating future nurse practitioners through her clinical faculty position at Johns Hopkins University School of Nursing and as an adjunct faculty member at the University of Maryland School of Nursing. And Dr. Santo Domingo has a rich history of service, having been a Peace Corps volunteer in Nicaragua as a community health promoter and participating in medical missions to countries like Peru, Guatemala, Ecuador, and the Dominican Republic, with organizations such as the Healing Hands Foundation and Mercy Medical Missions. And fluent in Spanish, she enhances her patient care and outreach efforts, reflecting her commitment to global health initiatives and excellence in pediatric nursing practice. And Dr. Erica Chiappini is an assistant professor at Johns Hopkins University in the Division of Child and Adolescent Psychiatry and Pediatric Medical Psychology program. She serves as the director of training for the Pediatric Medical Psychology Postdoctoral Fellowship program. Dr. Chiappini specializes in the assessment and treatment of child and teens with anxiety disorders and chronic and acute medical conditions, including gastrointestinal disorders. She provides cognitive behavioral and behavioral interventions to address anxiety, depression, and behavioral challenges. She's also a consultant for BHIPP, providing didactics on evidence-based interventions to social work interns. And her research interests center on factors associated with successful treatment outcomes in youth anxiety and youth coping with chronic medical conditions. We are very grateful to have you both here with us today. So thank you so much for sharing your expertise with us during the session. And I will hand it over to you guys.
Thank you. Dr. Keepy and I are really attached to the umbilical cord here. So although not the sexiest of topics, right? But okay, disclosures, no potential conflicts of interest, right? Yay. All right. So hopefully by the end of this great session, we will be able to identify, distinguish, differential diagnoses of constipation, differentiate between functional constipation and then, of course, organic disease contributing to constipation, and look at both medical and behavioral treatment strategies for functional constipation. Yeah. All right, as I'm sure you are all aware, constipation is just prevalent all throughout our country. I mean, in the United States alone, about 15% of all pediatric primary care visits are for the evaluation of functional constipation, right? So functional constipation, infrequent and/or hard bowel movements, fecal incontinence, abdominal pain. Basically, constipation in children causes emotional distress to the child and the family. And it definitely has a significant impact on overall healthcare costs in pediatrics. 3% of children presenting to primary care pediatric clinics are diagnosed with functional constipation. And in about 80% of these children, there's an association with fecal incontinence, right? Or overflow incontinence. And then approximately 1 to 4% of school-aged children experience fecal incontinence, representing about 3% of primary care visits, which, I mean, those statistics were back, I always say pre-COVID or post-COVID, right? They're back before 2016. So I'm sure those numbers have honestly probably grown. So clinical guidelines. So in 2018, there's a study performed by Barnes et al., who looked at the current trends in the evaluation and management of functional constipation in children and compared practice guidelines to the latest, as you see in front of you, SBGAN, NASBGAN guidelines reported in the systematic review that you can see right there, right? Responses were collected from 197 gastroenterologists, 116 gastroenterology nurse practitioners or physician assistants, and 206 pediatrician or primary care clinicians. They found low use of, at that time, applicable Rome 3 diagnostic criteria. Approximately 85% recommended testing beyond what is recommended, and over 1/3 did not perform several recommended tests. And over 25% did not make appropriate referrals. So further, there was little consensus in the treatment approach among the 3 clinician groups. And then basically primary care familiarity with these NASBGAN guidelines was very low. So we have our Rome 4 criteria for the diagnosis of functional constipation in children. So this was released in about May of 2016, but basically the diagnostic criteria for functional constipation, including straining, lumpy or hard stools, sensation of incomplete evacuation, sensation of anorectal blockage, and the use of manual maneuvers to facilitate defecation. And then, of course, fewer than 3 spontaneous bowel movements per week. They're basically unchanged from the Rome 3 criteria. But at the present moment, still, the most widely accepted definitions for functional constipation are the Rome definitions. So as you can see, they're divided up in, why did we go? Sorry about that. So as you can see, they're divided into 2 groups and based on the age of the patient. So infants up to 4 years of age have to fulfill greater or equal to 2 of the criteria for at least 1 month. And then children and then those greater than 4 years need to fulfill greater or equal to 2 of the criteria for at least 1 month. And then children in the latter group need to have a developmental age of at least 4 years. So that is important, and have insufficient criteria to fulfill the diagnosis of irritable bowel syndrome. As I'm sure you are all aware, abdominal pain is a frequent associated symptom, but its presence is not considered criterion for the diagnosis of functional constipation. All right. Should we have a poop every day? That's our goal. All right. So the gradual decrease in bowel movement frequency, as you can see here, the decrease in bowel movement frequency with advancing age basically correlates with a shorter transit time and varying patterns of colonic motility, right? So the mean total GI transit time is about 8.5 hours at 1 to 3 months. I apologize. I don't know why it keeps, advancing like that. I apologize. Look at that, touching it. About 1 to 3 months of age, and then 16 hours, as we can see here, 4 to 24 months of age, 26 hours at 3 to 13 years of age, and 30 to 48 hours after puberty. So this is important to understand, is the total colonic transit time to help with our treatment, right? Now let's go. All right. Basically, the medical workup for functional constipation is history and physical examination. That's it, right? And utilizing history, basically those Rome 4 criteria. The major role for history and physical examination, the evaluation of constipation, is to exclude other disorders, that present with difficulties with defecation and identify any complications, right? It was interesting. I was looking, and there was, back in 2018, there was a study, it was done in Turkey, but it was very interesting that it was a comprehensive study evaluating the presence of celiac disease among children with functional constipation resistant to treatments, right? And it showed about a prevalence of 1 in 28 which is extremely high, I believe, but were diagnosed with celiac disease. And we have our governing body, for children who are resistant to our, treatment for functional constipation. It is relevant that we go ahead and screen for celiac disease, right? So we do believe so does NASP again, that use of screening tests for celiac disease, thyroid disease should be considered in children with functional, when functional conventional treatment has not been successful, right? And we'll talk about it a little bit later, but early diagnosis prevents unnecessary, waste of time, but also less money and prolonged laxative treatments. So also demonstration of the presence or absence of fecal impaction also has, important therapeutic implications. Several studies have been performed to assess the value of scoring fecal loading on abdominal radiography in diagnosis of clinically defined childhood constipation. 5 studies were included assessing a value of scoring fecal loading on abdominal radiography and diagnosing clinically defined childhood constipation. So our governing body, you don't need it, right? You don't need an x-ray. All you need is that Rome 4 criteria, right, for diagnosis of the history. And then if you're feeling, palpable stool, either, on the abdomen or fecal impaction upon, rectal examination, that's all you need, right? So a plain abdominal radiograph can be used in children who fecal impaction is suspected, but you can't get the physical exam, right? There's always a way that you're not able to get a physical exam, right? Depending on that child. But overall, evidence supports not using abdominal X-ray to diagnose functional constipation, right? I usually typically use abdominal radiography to assess my changes, how the patient's responding to my treatment, right? So not to diagnose, but to see the outcomes, right? And if I can't physically examine them, but as you are probably all aware, the differential diagnosis of constipation is varied. It's all over the place, right? But overall, like I said, we talked about celiac disease, thyroid, hypothyroid. Interesting enough, everyone always asks about milk, right? Milk protein allergy. It was interesting that there have been several studies and there's conflicting evidence, but ultimately in our NASP began guidelines for the treatment of functional constipation, we do actually recommend for intractable constipation, right, that we can recommend about a 2 to 4 week trial of avoidance of cow's milk protein, right? But like I said, these are typically in children with intractable constipation. So allergy testing, not so much, but we could just do a 2 to 4 week exclusion of cow's milk protein and see how that responds, right? Just because, like I said, the evidence of saying yes or no, it's all over the place, but ultimately we do recommend for intractable constipation, right? So they're not responding to our treatments. All right, so like I said, all over the place. So typically, functional constipation, history usually starts a few weeks to months of life, and typically not at birth, right? We always ask about the age-old question, did they pass meconium within the first 24 to 48 hours of life, right? Huge indicator of diagnostic or looking further into Hirschsprung's disease. But for the infant and toddler, obvious precipitating factors coinciding with the start of symptoms, usually sometimes there's a fissure, change of diet, timing of toilet training, right? Infections, changing of households, and starting of like nursery daycares, right? There we go. Let's see if we So, with the child and adolescent, what we find is there's sometimes precipitating factors with the start of, fissures as well, changes in diet, infections, changing of households again, starting of school, fears and phobias, and major changes in families, maybe some medicines, new medicines, and travel. But this is what we, functional constipation, like I said, it usually starts a few weeks, months to life. No obvious precipitating factors. They all pass meconium. They are growing, right? Height, weight, BMI, they're all just chugging along their little curve, right? That's what we really want to look at. You may, like I said, abdominal exam, there may be a palpable fecal mass. And then we're looking at the spine. There's no, tufts, sacral dimples or tufts of hair on the sacral dimples. And there have, growing and developing on track, normal gait, tone is normal, strength, and reflexes, right? So if the history and physical examination findings are not consistent with organic disease, they're doing all those things that we just saw previously, growing on track and everything, then functional constipation can be diagnosed, right? So there's no red flags that we discussed in the workup, then functional constipation. So how does this happen, right? And that diagnosis is from the room for criteria. So typically what happens is there's, pain or irritation involved with defecation, which then leads to, I don't want to poop. So stool retention, right? As the body continues to absorb water from the colon, the rectum begins to accommodate stool and basically becomes atonic and desensitized. Larger volumes of stool accumulate in the rectum as the rectum continues to dilate, and the anal canal shortens and leads to the escaping of stool sometimes, which encompasses fecal incontinence, right? I don't know what is going on. There we go. So, usually an acute episode precedes a chronic course. So change in human milk to cow's milk, which usually has a higher protein to carbohydrate ratio. There could be a cow's milk protein allergy. For toddlers, toilet training. And I know these days, everyone is, there are many daycares that are requiring toddlers to be toilet trained before bringing them on, or like schools as well. And so we're seeing a huge impact of that, toilet training, which leads to a pattern of as well stool retention. In older children, what we find is retentive pattern, typically due to inconvenient or uncomfortable situations like school, right? So they will withhold. So what we said, these terms are usually thrown around interchangeably: fecal incontinence, encopresis, fecal overflow, incontinence, soiling, right? So in children, the term fecal incontinence incorporates both encopresis and soiling, the important difference being quantity of the feces lost, right? But basically, in the medical literature, the two terms are often used interchangeably. The most widely accepted definition for encopresis is the repeated expulsion of a normal bowel movement, whether involuntary or intentional, in inappropriate places. So in clothing, on the floor, by a child aged 4 years and older or equivalent developmental level. Soiling is typically defined as the involuntary leakage of small amounts of stool, resulting in staining of the underwear. So most those children with fecal incontinence, the problem is associated with underlying constipation or stool retention, right? Of those with constipation, 95% of those children have functional constipation. And the remaining 5% have organic etiologies, such as anatomical abnormalities, Hirschsprung's, a perforate anus, or some type of neurological defect, like some type of spinal defect. Childhood functional constipation with fecal incontinence is particularly associated with some type of behavioral, developmental, or psychological factor. Right? And then not all children with fecal incontinence, however, have evidence of excessive stool on physical or radiological examination. 20% of children with fecal incontinence are characterized as having non-retentive fecal incontinence. So non-retentive, like I said, is developmental delay, psychological stress, trauma, behavioral issues, neurodevelopmental disorders such as autism, and typically the treatment of non-retentive fecal incontinence lies a lot with behavioral modification and toilet training. So in our study, we saw, we'll talk about here a little bit later, that we conducted for our population at the Johns Hopkins Children's Center in our outpatient clinic. The mean age of onset was anywhere from 7.4 to 9 years of age. And typically what studies demonstrate is there's a 2-to-1 ratio favor of males, right? Males are more prevalent, but who we saw, our populations were exactly equal between male and female genders. And then, of course, you have parents do not understand why their child is soiling themselves. All right, so treatment of functional constipation and fecal retention. Disimpaction, very important, right? We got to remove that stool burden, and then maintenance therapy. Then we need to keep it flowing, right? Keep it going. Despite the relatively high prevalence of childhood constipation, large randomized controlled therapeutic trials have not been conducted to assess this condition. I apologize. All right, there are many studies to, I don't know, it's not a sexy topic. I don't know. Anyway, the treatment of constipation, therefore, has been experimental rather than evidence-based. Yeah, and consists of education, dietary modifications, and use of laxatives, right? Often the medical management of these children is combined with behavioral techniques, such as toilet training, combined with a reward system, diminishment of any type of toilet phobia, cognitive exercises, psychotherapy, cognitive therapy, family therapy, a lot of family therapy, or any type of educational interventions, right? The aim of this combined therapeutic approach is to lower the level of physical and emotional stress that is so often associated with defecation, develop or restore normal bowel function and habits by positive reinforcement, right? Preserve self-respect and encourage the child and parents to take an active role during the treatment, right? We'll talk about all of these here, coming right up. Disimpaction, so important, right? And I feel that this is a step that is often not recommended by our primary care clinicians out there. It is important to remove that retained stool in order for the maintenance therapy to be effective, right? So once again, there have been no placebo-controlled studies to evaluate the effects of a type of disimpaction protocol, looking at enemas or Miralax, for example. One study compared the effect of Miralax or polyethylene glycol to enemas, but could not detect any difference in effect. So The clinical guidelines by NASPGHAN that we utilize concluded that evidence shows that polyethylene glycol, Miralax, right, or Polylax, basically, and enemas are equally effective for, a disinfection. So in the NASPGHAN guidelines, you'll see a disinfection protocol of anywhere from, and we'll talk about this too, dosing according to weight, 1 to 1.5 grams per kilo per day, with a maximum of 6 consecutive days, or an enema daily for 3 to 6 days. But we know that enemas in these, especially this patient population, are very difficult to conduct. But at Johns Hopkins Hospital, this is the protocol for disinfection for our emergency department. So when children come into the emergency department, double abdominal abdominal pain, rule out appendicitis, and then on imaging, full of stool. This would be the protocol, right? With the most important factors being dosing according to weight, and as well as maintaining a clear liquid diet while performing any type of clean out, because how do you make poop? Through food, right? So, and here's some other dosings, right? Lactulose, it is, it's been out there, and I know we'll talk about this a little bit later, or Dr. Cupini will, is that lactulose is utilized as a osmotic laxative, being bring stool into the colon to make things nice and soft. So 1 gram per kilo, so 1 to 2 grams per kilo once or twice a day, right? Miralax, 0.2 to 0.8 grams per kilo per day. I just go up to 1 gram per kilo a day, right? Milk or magnesia, yeah. So as you can see, there's some good, there are some good dosings there. Mineral oil. I know there's some clinicians out there that still utilize mineral oil. Like I said, we usually tend to not utilize mineral oil due to all it does is coat the stool, making it so it's easier to slide out. But also what it does is it can also worsen or create leaking, right? Leaking of stool into the underwear. Stimulactives, very crucial. We have bisacodyl or Dulcolax, which we typically do not use for maintenance. So these are for maintenance, daily maintenance dosing, right? We typically do not use bisacodyl. It's a little harsh, and a lot of our patient population aren't able to swallow pills. So Senna or Senicides is typically what we utilize, and 1 square of XX chocolate is equivalent to 15 milligrams. So we do, after successful colon cleanse or disinfection, we do continue with a maintenance of an osmotic laxative, and depending on the specifics of the patient, they may require Senicides or Senna afterwards to help that bowel squeeze, to clear the rectal vault with a bowel movement, right? To have an effective evacuation of stool. Non-pharmacological treatments, fiber. Jury's still out on that one too. So unfortunately, in these studies that were all conducted, there's no information about randomization, blinding, nothing like that, right? And no statistical assessments were conducted. And like I said, no randomization studies that evaluate the effect of, for example, increased activity in childhood constipation. But fiber, as you can see, it's all over the place. So increase in fiber intake is not as effective as lactulose. And then pool weighted standardized mean was about 0.35 bowel movements per week in favor of fiber, which of course is neither statistically significant nor clinically relevant. typically, I know my general pediatric surgery colleagues who run a well maintenance or well management program, which is more geared more towards the surgical interventions or the neuro, like Hirschsprung's or a perforate anus. Those that patient population, he will recommend increased fiber in with psyllium fiber, right? For that patient population. Fluid, once again, increasing oral fluid intake is not shown to be beneficial. And it tells you, right, 108 children, comparing 3 groups, 50% water intake, hyperosmolar supplemental fluid, and normal fluid intake, found similar stool frequency at 3 weeks for the 3 groups. However, in our clinic, we just believe in hydration, period, right? It's a good thing. So we do emphasize at least a minimum of half their weight in pounds. Half their weight in pounds is how many ounces of water we recommend that the child drink daily. And right, do I have evidence to support that? No, right? To say like, oh, there's evidence, but we have found that it just for the overall good health of our patient population, we recommend it. So yeah, and that's at the regimen that we do. So half their weight in pounds is how many ounces of water that we recommend daily, right? All right, this is the kind of length, right? So of course, no randomized controlled trials have investigated the optimal duration of medical treatment in children with functional constipation. It depends. It's because every child is different, right? Based on expert opinion, though, maintenance treatment should continue for at least 2 months. This is important, right? And at least do toilet training. But what I usually tell families is like, look, you're going to be on this regimen for at least 2 months, then at which time we could see how they're doing. How are the symptoms, right? How are any type of accidents? Are we having daily soft bowel movements? At which time we can start to wean or titrate, peel off some of those medications slowly, right? But the maintenance therapy should continue for at least 2 months, at least through toilet training for those that are not toilet trained yet, right? All symptoms of constipation symptoms should be resolved for at least 1 month before discontinuation of treatment. And once again, we do wean children off of these medications, right? Oh, yep, treatment should be decreased gradually. And once again, in the developmental stage of toilet training, medication should only be stopped once toilet training is achieved. Whew, this is why I am very passionate about participating in these types of presentations with my primary care colleagues out there, right? Because it takes a while, and a delay in the initial medical treatment for greater than 3 months from symptom onset correlates with longer duration of symptoms, right? So out of pediatric GI referrals, thank you all very much, 50%, not a good number, right, will recover with greater or equal to 3 bowel movements a week without fecal incontinence and be without laxatives after 6 to 12 months. An additional 10% are well while taking laxatives. 40% will still be symptomatic despite the use of laxatives. And that number is what gets me the most a little bit. But there's other factors that, like I said, every patient is unique. And then a total of 50% and 80% of children are recovered after 5 and 10 years, respectively. Long time, with the vast majority of patients no longer taking laxatives. Like I said, the key point is that what studies have found, like Borowitz et al., they showed that a delay, primary care providers tend to undertreat children with constipation, and there's a delay in treatment, basically defined as the time between age at onset and the first presentation at Peds GI. So they found that if that's long, and then the durations of symptoms, is longer. So 80% of children adequately treated in their course recovered without using laxatives at 6 months of follow-up, compared to only 32% of the children with a delay in treatment. So that 3-month mark is important. And that's why I know Dr. KP and I have a very long wait list. So that's why I'm so passionate about presenting this information to our primary care colleagues, that there's, some things that we can do prior to the consultation with us. So, and
all right. Yeah. So now that Dr. Santo Domingo has done such a lovely job kind of explaining, how do we, on the medical side, kind of manage constipation? How do we actually get our families and our patients to kind of follow the regimens? Because I'm sure, as many of you have encountered, is they say Miralax is tasteless, but like 95% of kids can find it and will start to refuse it, and parents hide it, and then all of this kind of happens. And so the treatment of constipation can be incredibly frustrating. And so when studies have looked at kind of treating functional constipation from a medical standpoint alone versus the medical and behavioral kind of combination, which is what we do in our clinic here, we are, looking to see how do things differ. So on the medical side, what we're really looking at is what's the education we're providing families around kind of constipation, and how are we altering their perception of what is happening with their kids and their constipation and their accidents. Making sure that they get a good disimpaction, and then providing that maintenance therapy. And then when we look at what happens when we have both the medical and the behavioral piece together, we have, that education, disimpaction, the maintenance, plus working on scheduled toileting, using reinforcement for different behaviors related to constipation. So things like completing their sit schedules, actually letting their poop out instead of holding, taking their medications, things like that. And then having parents really use what we call differential attention. So paying attention to the behaviors that we want to see more of. So when they make attempts at going to the bathroom or listening to the urge that their body gives them or things like that, and not paying attention to the behaviors that we want to see less of. So when they're refusing their medication, or even withholding behaviors themselves, we kind of sometimes walk this fine line of how do we kind of help steer one behavior in favor of another. And what we see is that the combination of kind of the medical and behavioral can be actually very, very helpful. And so when we looked at this in our own clinic a couple of years ago, what we saw is, so the way our clinic is structured, everybody will see Lisa first to kind of get the initial history and then treatment plan. And then one of either myself or one of our psychology fellows will kind of see the family immediately after to say, okay, how are we going to get this plan to happen in your home? And so what we've seen is that there is a significant decrease in both bowel accident frequency, the occurrence of abdominal pain, the use of diapers. So our kids who are like, toilet training age, but have not been able to toilet train just yet because of their constipation. And then the parents' perception of constipation all get better, right? So we see less diapers, less pain, fewer accidents, more regular bowel movements. Can you go back? Yeah, thank you, Lisa. It's a phantom today. And so that, kind of having that combination is very helpful. And what we've also seen too is that most patients and families benefit from having a single clinic visit. So just getting that initial information and then kind of getting a structured plan for how to implement it can really have a meaningful impact on how well their kids do from a constipation perspective. On the flip side, the kids that have kind of a more severe clinical presentation, so maybe their bowel accident frequency is kind of, several times a day, or they've really had a long process toilet training or things like that. These are the kids that often need a few visits in our multidisciplinary clinic to help them achieve those optimal outcomes. So that way we can start to problem solve some of those things that have been a challenge initially. And so when we think about this, like, what do we mean when we're talking about behavioral health or pediatric psychology, and how does that relate to constipation? And so we'll, I'll kind of dive into this in a second, but also what is, the rationale for the behavioral interventions that we put into place for fecal incontinence and constipation. And then what are some of the goal for today is like, what are some of the behavioral strategies that we can give you guys to kind of implement with the kids and families that you see early on to hopefully help the ball get rolling. And then we'll kind of end with a couple of case examples that put this all together. So pediatric psychology is really a group of psychologists who have worked with kids with chronic and acute health conditions. And so we get this specialized training over the course of our graduate school, our internship, postdocs, and different work experiences. And what we can see on the whole is that having a pediatric psychologist involved can really contribute to having better outcomes for our kids that are experiencing a variety of medical illnesses, with GI included in that picture. What our focus tends to be in these groups is working on adherence to the medical regimen. So whether that's, getting an enema done or taking your medication each day, different things like that, is that, we often tell families to do these things, but then sometimes they go home and they say, my kid refuses this. I don't know how to get this to happen without, causing so much drama in the house. We can also help kids learn to manage their pain. So when they do have that, kind of maybe lingering pain, both how do they manage it, but then also how do we, kind of help prevent future episodes from happening, helping them adjust or cope with their specific difficulties, and then really providing kind of behavior management strategies to parents, particularly for our younger kids. You can go to the next one. Yep. And so what do we focus on in our constipation clinic specifically? So one of the big ones, and a lot of these will depend, are a little bit, kind of vary depending on the age of the kid that we're seeing, but these are the major ones that I would say we spend most of the time. So especially for our younger kids around that toilet training age is stool withholding. And, you've probably seen this too, the number of kids that have come in, like, the parent will say like last March, they had this one giant painful poop and they have not freely let a poop out since then. So like for our little kids, right, having a big incident like that can really have lingering effects on how their kind of potty training and toileting habits go. And so one of our first goals is how do we help kids, both on the medical side, have softer and more frequent bowel movements, but then how do we also help them kind of cooperate with what their body wants to do more easily too, and so that way they can let it out more freely. Potty training refusal, which is closely tied with constipation, right? So we are often talking with parents about, well, first we got to get them to let their poop out easily, and then we can focus on potty training. So we definitely try not to do both at the same time, just so we don't overwhelm the kid and overwhelm the family. And then, of course, kind of working on the medication adherence piece. We also see, especially in some of our older kids, so like those elementary, maybe middle school kids, where they are fearful of the pain that constipation may bring. And also kind of using bathrooms in general, right? So it's like when my stomach hurts most, that's, they kind of have this association of pain with being on the toilet. And then lots of kids, especially in school, will withhold throughout the school day for a variety of reasons, right? Like I've heard some terrible horror stories about what middle school bathrooms can look like. Or kids saying, everybody's going to know what I'm doing, or I don't want them to know that I have to use the bathroom or that this is going on. And so really kind of addressing some of the anxiety pieces around that is one of the things that we'll focus in on our clinic as well. And what we see just kind of in general is that our kids with constipation do have higher rates of internalizing symptoms. So things like anxiety and depression, and also externalizing problems. So like more likely to have attention difficulties, ADHD, disruptive behaviors, acting out, things like that. And in general, our kids with constipation and their families have a poorer quality of life compared to kids that do not have those, and even compared to other kind of groups within GI too. And so we know that this difficulty with pooping can really have kind of some significant impacts for our kids and our families. Some of the kind of consequences that we see, especially related to fecal incontinence, can really vary across the settings that we encounter the child in. And so one of the biggest ones that I know we kind of focus on, and we provide a lot of education in our clinic about this too, is that parents will come in and say, my kid's having accidents on purpose, right? They are doing this. I don't understand why this keeps happening. I'm so frustrated. They just, they've already been potty trained. Why can't they just get it in the toilet? And so we really provide a lot of education around like, you know what, the accidents may not be within your child's control. And so kind of giving that corrective information helps parents kind of tackle constipation from a different standpoint and gives them a little bit more buy into the process too. And so we will kind of spend a lot of time working on that too. And so we really try to take away that constipation and incontinence in particular is kind of a purposeful behavior, and really kind of talking about like how we've gotten to this place. And I'll share a video with you guys that we often give our families too. And so we try to encourage families to kind of reduce blame or punishment for their child for having accidents, and instead try to reinforce the behaviors that we want to see more of. So how do we have your kid kind of cooperate with the regimen that we're going? How do we help them sit on the toilet more often? Things like that to kind of encourage the behaviors that are going to help them overcome their constipation long term. Related to this, which I'm sure you guys have seen, is that a lot of negative parent-child interactions can kind of blossom from this, right? Because the parents are frustrated that they're having to buy, mountains of underwear all the time. The kid is frustrated that their parents always nagging them to go to the bathroom and things like this. And so things really just kind of cycle pretty terribly over time. And the longer it's been going on, the worse the problems tend to be. And so we also try to focus on how do we change the interaction that parents and kids are having, especially around this issue too. Thinking about our kids in school, especially as they're getting in those older kind of elementary school years, right? So third, fourth, fifth grade, if a kid is still having accidents, there is a lot of kind of social risks that could come with that, right? So we might see kids that are more likely to have peer rejection or be stigmatized or get bullying from their peers for having accidents, or maybe they're still wearing pull-ups or things like that. And so, again, we really want to be addressing this so that way we can stop some of these or prevent some of these long-term outcomes. We've even seen kids, especially I would say more, and Lisa, correct me if I'm wrong on this, but especially our kids that are like in middle school and high school, if they've been dealing with constipation and accidents kind of throughout this time, we also see a lot of school avoidance, or they have increased abdominal pain from their constipation. And so they're not going to school as frequently, which then again, we're entering a new kind of cycle that's can have some pretty major impacts. And then just in general, just kind of having lower self-esteem about things. And so that's what we kind of focus on with the kid individually, especially as they get kind of more cognitively advanced, right? Like we're not going to have these conversations about how do your friends feel about this for a 2, 3, 4-year-old, right? But once we're kind of in those elementary and middle school years, that tends to be a piece of what we look at. And then we also really work closely with parents to kind of help them realize the role that they can have in kind of helping to overcome some of the behaviors that have happened as a result of constipation. So one of the areas that we'll focus in on is what are the beliefs that we kind of talked about this a little bit about that parents hold about constipation and just toileting behaviors in general, and how can we, provide different education to help them come from a different place that may be more helpful. Giving parents information about the reasons that we're selecting certain medications to help manage their kids' constipation. So why are we giving Miralax and X-Lax, for example? What is that going to kind of help do for their kid? And then also just kind of putting into place, like, where is a child developmentally? And I would say this is definitely a frequent conversation for like early potty training kids. And like Lisa was kind of saying earlier, right? Like, my kid's going into pre-K 3, in the fall time, they have to be potty trained. Some kids aren't ready to be potty trained until they're 3 or 3.5, right? And so kind of how do we help parents kind of strike this balance of like, we got to slow down, because the more pressure you put on your kid now, the less likely they are to potty train. And I know you have this thing looming, but let's focus on like, what can we control at this moment? And then we can partner with the schools to kind of say like, hey, this kid has this constipation thing going on. We can work on some accommodations to kind of help support that while they're in their schooling setting. For parents giving them more specific practices that they can use. So how do we help parents kind of monitor their kids' symptoms without being too much of a nag about it? Making sure that they're, kind of following through with the medication management piece. So like if a parent is forgetful of giving medications, how can we support them in making sure that they get them each day? And then for the kid that refuses their medicines, how do we help parents kind of work together with their child to be able to take that more consistently? A lot of this has to do with parents setting kind of clear expectations around toileting behaviors. And so, like first you take your medicine, then we go out to play. So kind of helping parents be really structured in their approach. And same thing for like, using the toilet before they go out to leave for the day or things like that. We also know just in general, kids really like routines. And so the more routine-based we can be about medication adherence or toileting, the more successful our kids and our families are going to be in kind of following those routines. And then really working with parents, and we highlight frequency here, right? Because like a lot of parents will be like, take this, take this, take this, and then kind of being a little too persistent. And so the more that happens, the more our kids dig in. And so again, if we can use the we always go to the bathroom before we leave for school and right when we come home, kind of integrating them into routine, so that way parents don't have to provide quite as many reminders and prompts that can really impact that child-parent relationship over time. So kind of reflecting of all of this, I'm trying to be mindful of the time here too, is as the kind of medical provider, in primary care, you're probably the first person that our kids and families are seeing for this. And so what are some of the strategies that you can give in the moment to kind of help your families dealing with constipation? So I think, we tried to, Lisa and I yesterday in clinic, we're trying to think of like, what are the real highlights that we want to make sure are kind of clear from this presentation, right? And I think these are the ones that we kind of came up with and the ones on the next slide too. And so it's really that the accidents are not necessarily in the child's control for the most part, right? There's going to be a couple kids where that is the case, but I would not use that as the baseline. I would provide the education to the families that's like the accidents are frustrating for sure, but your kid is not doing them willfully. I think this next one is also one that comes up, especially for our kids dealing with functional constipation, is like some kids are pooping like 3 or 4 times a day, right? And they can still be dealing with constipation. And that just tells us that when they are going, they're not fully clearing out the rectum, right? And so again, providing that education to families that's like, yeah, it makes sense. This is confusing. Your kid is going to the bathroom a lot, but because they're not clearing out, that's why we continue to have these difficulties. Really making sure that we get a good full disimpaction at the beginning so that we were starting from a nice clean slate. So that way the medications that we do daily can really do their job as best as they can. Making sure that the dosing is great. And we're really kind of focused on getting the right stool consistency. So in that Bristol stool scale, we're looking for that 4 to 6. So that way things pass easily, and without kind of too much work. And then when families are doing well, we've seen many families where it's like they were doing great for 3 weeks, so we just stopped the medicines. And so really providing that education of like, your kid is not becoming dependent on these medicines, but we also don't want to pull the supports too fast. And so we work on a kind of a gradual wean down process before we just kind of stop things cold turkey. We also in our clinic, especially for all first-time visits, show family this Poo and You video, which is about 5 or 6 minutes long and kid appropriate. And so we show that to parents and kids. And oftentimes we kind of walk in and they'll say, oh my gosh, we learned so much from that. And so I think this is a helpful resource that you guys can share with your families who have been struggling with this for some time. We also I think it's helpful to provide a lot of education about the medications themselves. One that comes up very often in our clinic is that families will worry about long-term use of Miralax or just Miralax, and even for short terms, and the relationship that has been kind of promoted with behavior problems over time. But the reality is that have been no research studies that have linked the use of Miralax with more behavior problems. Some of these have really just come about from anecdotal reports. And there was like a New York Times article, I think, back in the early 2010s that kind of, was not the most helpful in helping to alleviate some of these concerns. And this is where we provide the mix for families too, right? It's like, so it's not the Miralax, right? But we know our kids dealing with constipation and incontinence are just more likely to have behavior problems in general. And once you've been dealing with constipation for a while, everybody's feeling frustrated and irritable, right? We're in pain, things like that. And so like, that's probably the source of those behavior problems versus the Miralax. It's more of like a coincidence kind of situation. There's been no studies that show any kind of dependence on medications, right? So for Senna or Miralax, a lot of families will kind of ask about that. And so again, we're providing that education that these are medicines that really just operate on the colon itself to either add water or to offer a little stimulant. It's not something absorbed by the body. And, and we're playing the pros and cons game, right? Like constipation has been a difficulty. And so we want to be using these to kind of help with that. So that way we can prevent some of those downstream effects. And then lastly, on the behavioral side, and I think we have some case studies after this that we might have to blast through if we want time for questions, but we are really working with families to kind of identify for our toilet trained kids times that they can schedule times to sit on the toilet. So after we've been dealing with constipation for a while, the brain gut connection kind of weakens, right? So our brain does not do as good of a job of listening to our body's cues about when we need to go. And so we want to implement sits throughout the day to provide the opportunity, if there's stool in there, to release it, but also to help just strengthen that connection in general, right? So the kid that says, I don't have to go, they sit on the toilet and nothing happens, is good confirmation for the brain of like, okay, that was an accurate signal to listen to. Or maybe they sit when they felt like they didn't have to go and then they pooped. That is also helpful information, right? And so we want this kind of scheduled time. And we try to have families kind of aim to do their sits after meal times because of the reflex to kind of clear out. But the approach I always take is like, that's our ideal. Really, we're just trying to get some more opportunities for your child to like get a chance to poop. And so if it makes sense to do it like right when they wake up and right before bed and after lunchtime, that is great. We'll take advantage of the things that we can, but it doesn't have to be kind of super hard and fast. And then we really work with parents to use kind of appropriate rewards. So a lot of families will be like, I'll just send them to Disney World if they would just poop on the top potty. And we really want to try and break it down, right? We want something that's going to be immediate and daily, and as close to the behavior as we possibly can for it to be kind of the most impactful. So working with family to find the right reward for that, and for rewarding the things that are within the child's control. So like letting go of their poop instead of holding it, doing their sits, adhering to their medicines, and trying not to avoid for being accident free because we don't think that's within the child's control. We also want parents to be really neutral when kids do have accidents so we can avoid that kind of negative interaction that happens. And then this is just kind of another kind of quick things is like the simpler, the better for families. Things that are too complicated are not going to get followed. So keeping a consistent kind of routine-based schedule. So after meals or before we leave the house, first sit schedule, focusing on the target behavior, shaping smaller steps, right? So the kid who's constipated and not toilet trained, like first let's get their poop out, and then we'll slowly shift where they're actually going to the bathroom. So maybe it's still in their diaper outside of the bathroom, but at a certain spot, and then we move that spot closer to the toilet over time. So that way the kid is experiencing successes along the way, which is going to help kind of boost their behavior over time. And then just, again, we kind of talked about the rewards piece already.
I think now
yeah, go
might
ahead,
be a
Lily.
good time to answer some
Perfect.
questions.
Yep.
If there's any time left over, but we have a couple of questions.
Yeah.
First one in there is different departments at Hopkins have different bowel clean-out regimens. Is there any agreement over which regimen to use, or is there any comparisons?
I'm so frustrated by this. No, so the one that was presented is what I know our ED has, and it's even GI dependent. There's variations amongst our own GI colleagues, my own GI colleagues, about what to implement. What I have found this is the problem with not having evidence, right? Or having studies out to be like, okay, what I've noticed a lot is it's those volumes and the dosing of stimulant. Our nurses are getting a lot of phone calls that, oh, they're vomiting, they're not tolerating it. So many of you might see one of my clean out regimens, which it's hourly, giving some type of lower dose hourly, but once again, I don't have any data to support that. But yes, I would say just to make sure, the best ones is to have a stimulant on board. And like I said, at least through this protocol that I demonstrated that we have, there's a stimulant on board, clear liquid diet, and some type of osmotic, agent until that stool reaches a clear broth-like in nature, right? So that's a major thing, clear liquid diet, stimulant, osmotic, until they reach clear stools.
Thank you. We're at 1. We have a couple more questions, so if you can stay on and answer any. For anybody that has to hop off, thank you so much for attending today. It's okay. The recording of today's session, the slides, and a list of related resources will be available on our website next week. We will send CME and CU certificates to participants by March 20th. Just remember to take the survey as you exit, as this is required if you'd like to receive CME or CU certificates. And we will also send that survey out to you via email as well. So if you need to hop off, thank you so much. For those that can stay on, we have a couple more questions. Next question is, can you overdo Miralax? When I worked in the floor, we would have kids come in for cleanouts and they would get Miralax every 2 hours. But I see the Hopkins guidelines are 2 times per day. Well, I wouldn't do it every 2 hours at home. There's a big difference.
And are we talking about maintenance?
I think for cleanup.
Cleanouts.
Exactly. That's the thing about the volume. So typically what I have found successful for at-home cleanouts is for those greater than 20 kilograms. I'm sorry, 30. Those greater than 30 kilograms, starting off with either, 20 milligrams of bisacodyl dulcolax, which is the same as on the protocol, right? But then I'll do 2 capfuls of Miralax every hour. 2 capfuls of Miralax mixed anywhere in, 8 to 16 ounces every hour until stools reach clear broth like in nature, right? While on a clear liquid diet. If by dinner they're not clear, give them a light and quantity dinner, restart the entire cleanse the following day. What I always tell families is once you give that stimulant, they're not going to go right away. They're not, right? So I tell families, wake them up early, give, and if you can't take pills, use the XLX chocolate, right? So anyone less than 30 kilos, I might either 1 to 2 squares of XLX chocolate to start, and then 1 capful of Miralax every hour, right? And what we have found is that kiddos are more likely to tolerate and not throw up, right? You'll see on the protocol, you start with a stimulant, wait for 3 hours, try to drink a boatload of Miralax within 1 to 2 hours. Bleh. They're gonna, especially the kiddos that are undergoing these cleanouts are severely impacted. There's large volumes of poop. That's what landed them in the ER, right? So if it's not coming out one end, it's coming out the other. So what I found that doing the hourly Miralax and having kiddos drink it every hour, not only does it keep them full, believe it or not, you're not waiting for 3 hours and being like, I'm hungry. It keeps them full while also helping to not vomit. So I know.
I think it really helps the little kids too, because I don't know if anybody's tried to get like a 2-year-old to drink a large volume. Having a smaller volume spread out, more frequent over the day is sometimes a little bit easier.
Thank you. I think you might have actually answered the next question in that response, but I'm going to read it just in case. It says, I have kids where I've done a clean out, but it was not successful. Do I repeat it the following day? I work with kids in psychiatric residence, and they may or may not be cooperative with a repeat. If I do repeat it, do I let them eat in the evening between the 2 days? And I think you covered that.
Reward, right? So exactly. So start it, and then if they're not clear by dinner, give a light and quantity dinner, but restart the entire thing the following day. Yeah.
Okay. And it looks like this might be our last question. Do you feel it's appropriate using an X-ray to confirm a diagnosis of constipation when parents are not convinced of the diagnosis?
I am very good at telling families about our Rome 4 criteria. Johnny didn't even have to come in, right? Like just based on your history alone, I could diagnose it, right? And I tell families about, I explain Rome 4 criteria, and Johnny fits. But, I like to save my x-rays for any changes I implement, right? So what I'll do is if the child, if there's just history and physical exam of even palpable stool, I don't have x-ray hands, but I could tell you they're constipated. So let's do a clean out. Let's save that x-ray to be done locally by where you live after the clean out. Because I made a change in a plan. I implemented a plan. I want to see what effects that has on the child, right? So then, yeah, then I get buy-in, right? Let's save my x-rays for something, to see if this works. Because sometimes if a kiddo's really impacted, they might run clear. We get that status post x-ray the next day, that as soon as possible. And there's still like moderate to average stool burden higher up in the colon, right? That lets me know, oh, they need, it's going to change my treatment plan, right? They might need a little bit more stimulant than I normally would give, right? And then I have evidence to show the family, like, look, yeah, this is why, we're still dealing with this problem, because he's never undergone a successful clean out, right? So I like to, like I said, I like to save them for evaluation of outcomes, or when I can't physically examine a kiddo.
There was a follow-up question, but I think you might have answered it too. It says, so by changes, if they say they're not doing better, is that when you would do an X-ray? Okay.
Yeah.
All right. Well, thank you both so much for this wonderful presentation, and to everybody that attended today. Again, please fill out that evaluation survey if you'd like to receive CME or CU credit. We'll send it out via email as well. And thank you so much, and I hope you have a great rest of your day.
Thank you, everybody.
Thank you.
Thank you.